Right. So still on the PC, so the presenting complaints must capture the cardinal symptoms of the disease. And it must be what one of those cardinal symptoms that the patient will tell you that you capture under the presenting complaint. So if it is BP here, for instance, if the person is talking about, oh, I was told my BP is high. BP being high is part of preeclampsia. So I'll capture that because it is cardinal symptom of the disease. I'll capture that as part of the presenting complaint the patient mentioned. Okay. So whatever you are going to mention as the patient complaint should capture the cardinal symptoms. Cardinal means the most important ones, the most important symptoms of the condition you are dealing with. So it's not just anything that the patient tells you. You are gathering information. So it should be guided. It should have context. It should be linked to what you are. It should be in context. Okay. So you gather what the patient says, but what the patient says that you are going to put down as a present comment should be something that contains the cardinal symptoms of the condition you are dealing with. Okay. It can be one or two or three. Okay. If you have two impressions, okay, then you can have one for each. So it should be the major one. The others you can talk about under the history of presenting complaints. So let's always have it. I'm going to have one or two or three, maximum three, for my presenting complaints, and those should be cardinal symptoms of the disease. Okay, and no matter what, the patient can will mention something in connection with the cardinal symptoms, because that is what will make them come to hospital. The patient will not come to hospital if they don't have, bothersome kind of symptom. They will not come to you. So they will definitely mention that one, which is you think that stands out so clearly, or that is linked to your preeclampsia, is what you capture under your presenting complaints. Okay, so you capture it in the patient's words in there. Then you come to the history of presenting complaints. So when you come to the history of presenting complaints, this is how it should go. Then I put this in here. I'm going to draw it here. Okay. So the history of presenting complaints should go like that. Usually like this. I always put it this way. Okay. So you see that here the patient is at the base. So in the baseline, maybe the person is diabetic, the person is a sickle cell patient, is hypertensive. Okay, now the condition now comes. Now the condition will start. Usually maybe the onset may be what? Slow, gradual, acute, or fast, and so on. Okay, so the kind of onset should also tell something about the condition. So the type of onset, was it acute? Was it gradual? Sometimes insidious. It means the disease will be going on, the patient will not know. Okay, so apparently was well until, and then it's telling you that kind of insidious kind of thing. Okay, so then the symptoms will go until it hits a peak. The peak is where the patient will say, no, now I'm sick. This thing I need to go to hospital, and that is the peak I'm talking about. So at that peak, that is when they are coming to you. They will visit the facility. Okay. So usually, if you are at the tertiary institution, it's not likely you may pick these people up at the time that they are coming with at the peak of their symptoms. They may visit a nearby or a community facility before coming to you. So here usually will be the primary health clinic. Okay, it doesn't mean it's always so, but most likely I'm giving a hypothetical scenario. So here, let's say if it's preeclampsia, maybe our patient was diabetic. So the baseline diabetic gets pregnant. Okay, now around 22 weeks, the BP shoots up. So he or she visited the primary facility, and then she was stated to have high BP. So that is where the picture comes in. So this is where they are going to report now, because this is a symptom, a major symptom of the condition we are dealing with. So here the primary facility is visited. Now what do they do? The primary facility, if they are unable or they don't have the means to deal with the condition, then the most probable thing they will do is to refer them to you. So let's assume they are referred. Still, remember they are in the phase of the condition. Either the condition may go up a little or may plateau and so at this phase they are coming to us, let's say those at the tertiary level, okay, Koyebo Konfanochi teaching hospital. So right, so at this point they are coming to you because they have been referred. So here is the reference now. So I'm giving a picture so that when you are writing your history, it follows that chronology must be there. If that chronology is there, then your history will follow. right? If you don't have that link, if you don't have the sequence, you will not tell a good history, right? So the chronological aspects is very important. The time from what to what, from what to what, makes your history flow when you are reading it out, right? So at this point, they are coming to you at the tertiary. At the tertiary, when they come to you, you have this information with you. But here, like we said, the presenting complaint of the patient is going to be on account of referral. That's what you are getting. Okay, so your PC is going to capture referred on so and so on account of high fever, on account of high BP, on account of this and so. So that is what you are getting as a presenting complaint. Okay, that is if it is one condition you are taking. That is what you have. Now, when you come to the history of presenting complaints, you first would have to start from the baseline. So get the other work so that you can give a very good history. And when you do that, even your history, if you're presenting, your history is so good, your examination fine, you may fumble here and there, but it will save you at the end. Okay, a good history taking is the first step. It's a good impression at the examination room, right? So here, when you come to HPC, you are going to start from the baseline of the patient. If the patient was well, there was no condition, no bad condition, or the patient was in a state of what is diabetic, whatever, for how many years and so on this drug and that, until she got to 22 weeks, reported at a nearby facility, and then she was told the BP was high. She was therefore referred to CAD or Confanochi for further management because they do not deal with high conditions of this nature. Okay, she was told so. So she comes to you. So once you get the baseline up to the point she's referred to you. Of course, once you get to the baseline, you are now going to narrate how the condition started. So for instance, I would say, okay, so my PC patient was referred. My patient was PC will be what referred here on account of what high BP from the general hospital. That's my presentation. That's what the patient told me. The patient said, I was told to come here because my BP is high. So I will say, told to come to Confanochi, told to come to Kolebu on account of high BP. That's my present complaint. Now when I come to my HPC, I'm going to start all over from the scratch. And this is where I must get the progression of the condition from incubation to symptoms presentation to worst symptoms or peak of symptoms for the patient will report to what when the patient reported what has been done for the patient to the point that the patient is coming to me and what I'm also going to do for the patient. Right, so let's see how I'm going to start in my HPC. So I will probably say client was in her usual state of health and had conceived maybe about 3 months ago, was a regular attendant at the Lagina Hospital until about 3 weeks ago when she was told her BP was high or her BP had risen, okay, or had gone up, okay, right, and therefore she was given a referral note to CAD or to Kolebu Teaching Hospital for further management. It can be as simple as that, okay, or you can also, somebody also say client was in her usual state of health, or client who is a non-sickle cell disease and being managed at Confanochi sickle cell maybe clinic or whatever, was 20 weeks old or 20 weeks old with a pregnancy, or had a 20 weeks gestational had a 20 week gestation pregnancy and a regular attendant at La General Hospital. She was told her BP was 140 or whatever, and so on and so on, at her last visit, and was given a card to report to Kolebu Teaching Hospital for further management. Right. Sometimes they are made to do scan and other things. You can either, so you see the history of presenting complaint is your decision. You have control over that, okay, and you are going to make your listeners take what you are putting here. So it's what you put here what all that you do is you try to put all the symptoms that will speak for the most important ones that will speak for the condition, put them in the history of presenting complaints. The other less relevant ones, you can push them some to the on direct questioning, some to the systemic review, some to the other component that we'll be talking about, maybe drug history, past medical history, gynecological history, and so on, obstetric history. So you choose the best that will speak for the condition, put them in the history of presenting complaints. The rest that you couldn't capture under history of presenting complaints, then you put them under the ODQ, the systemic review, and then the other points. So that is how it should go. So from here, the baseline was onset. How was the onset like? The progression to the peak. How was the peak like? This was severe pain that she has to be rushed to the hospital. And when she got to the hospital, what investigations were done? What conclusion did they make? Why did they say they are referring the patient to you? So those things will come into the picture. So see that you have a lot to say anytime. So it's not like you'll be lost for what to say. If you go always, and it is always like this, there's a baseline, the onset, the progression to when the symptoms is so severe that they have to report, they report, whatever is done for them at the primary center, that is done. And then when that is beyond the primary center's ability, then they are going to refer them to the tertiary institution. Of course, when they come to you, at that point, it's on account of referral, and you quote one of the cardinal symptoms of the condition in the referral condition, the referral note you are going to put there as a presenting complaint. You quote one, at least one of them, the major one, as one, and then the progression of the condition will go. Okay. Now, at your point, what are you going to do? Carry out more investigations, or carry on with your management? How is the management going to go like until you are able to take care of the condition, bring it down to the patient's baseline, right? And that is how the history of presenting complaints will go. So your presenting complaints, your history of presenting complaints, they are very, very important. Once you get these two very well, the others will follow. Right, so you see here, I put it here like that. 22 weeks, okay? The person's BP goes up, okay? Now she's at 28. These are the cardinal or the milestones that are important in obstetrics, okay? At 22, then we put even 24 here too, okay? 22 weeks, okay? Maybe the BP went up. 24, other things may be done for the patient. Sometimes screening for diabetes may be done. 28, the same screening may be done. Sometimes we give anti-D, okay? Like so those things, and then we want to check the HB, because at this point we think the dilutional effect of pregnancy is getting to its end. Maybe at 32 weeks or 28, we do that. 34 is one of the points of saying the lungs are going to mature, okay? So certain things will be done. Can we deliver the patient because they have immediate life-threatening conditions, okay? If not, can we buy up to 36? No, be at 36, we are now going to decide. Some pregnancies you can decide what you are going to do for the patient from the scratch. Unless it is at 36 that you are going to decide what to do. Sometimes at 36, that is where you want to see whether the pelvic is adequate. So your pelvic examination may be done. Sometimes at 36, you think if the patient was breached, if the baby was breached and has not turned, you may need to put in some maneuvers, okay? Is the patient complying with that or not? So then you do your decide on that between that. Around 38 to 40, okay, that's 10. 10, as we say, is 38 plus 38 to 40, okay? So at that point, is that going to be the point that you want to deliver the patient? Is it 38? Is it 39 that you are going to deliver them? Is it for a medical condition? Is it for an obstetric condition? So usually, most conditions which are medical, you want to come early, you want to deliver them maybe 38. Those which are obstetric, maybe you want to go 39. Okay, but there is a controversy. Some will choose 39 for almost all the time, right? But of course, 10 is what? 40 plus or minus 2. So your 10, as we define, is 40 plus or minus 2 weeks, okay? That's your 10, right? Okay, so when people say at 40, if you go beyond 40, that is post-date. Some will say post-date, but some will take post-date with something else, okay? So post-date, you have gone beyond 40. Now, if you go beyond 42, that is a prolonged pregnancy. That is prolonged pregnancy, okay? And of course, we have post-maturity. Post-maturity doesn't matter the gestation. It's just that the baby is showing signs of malnutrition. Signs of malnutrition, the skin wrinkled, long fingernails, looks, the face, the eyeballs are staring at you, and all that, okay? There's loss of subcutaneous fat, So that is a complete intrauterine malnutrition condition, not related to a gestation. Just that it will tend to be more, it will tend to be seen after maybe post-date or prolonged pregnancy and so on. Right. So once you know the progression, that's it. So when the patient delivers, say by SVD, now it was the SVD, did it need instrumental delivery? Did we need to add something, assisted vaginal delivery? Okay. Using vacuum, did we need to use forceps? Okay, sometimes even episiotomy, okay, to aid your delivery, right? Okay, and then, or if the cesarean section, what was that? At cesarean section, what was that? Was it going to be a difficult, a challenging delivery that maybe a particular modified incision had to be used, maybe a J incision have to be used because the transverse and so on, the baby maneuvers will need to, okay, a very small baby, so you need to be delicate with it. Get a wider incision to be able to deliver the baby's segment. Okay, now did you need to go classical on the uterus, and therefore you would want to do BTL, depends, or you still do not want to do BTL, but you want to make sure that when the patient gets to 34, 36 weeks, you admit them, okay, for your final intervention so that you have control, you do not let them go into labor and then start go into rupture, okay? Of course, so from 36 weeks onward, you think labor can set in, so you want to deliver them before 36. Or the previous pregnancy, the death occurred maybe around a certain gestation. You do not want them to get to that gestation, so you deliver them before that gestation. All these things will come into the picture. Of course, after delivery, the next thing is you are looking at your contraception. It's important that the patient will come to you earlier than you anticipated. Okay, so the conception, which one are you going to use? The progesterone only, that it can be used earlier. Okay, or the combined one, which you want to use when breastfeeding has been established. Okay, right, so that goes on. Are there other methods? Can we use the IUCD, intrapartum? Okay, that is the cesarean section, post-placenta IUCD section. Okay, right, so on and so forth. So all these things will come to me. Or the kind of the BTL that we want to do immediate, okay, postpartum, the first 24, 48, maximum 48, 24 hours you are doing it, okay, or you want to do the interval, you want to wait maybe after there are some weeks over, okay, beyond into the one beyond the postpartum before you do your interval, or what do you call it, your eradication of the tubes may come, right? So these are the things you need to do. So this is a chronology, and it's a picture for almost all conditions under us and gyne. Right, good. So your PNC also comes in, okay? Right, some conditions will resolve 6 weeks postpartum, some may go 3 months, some may go 6 months. In fact, for those that will affect connective tissue, they may go up to 6 months. So some hypertension diseases may only clear after 6 months. Of course, if the condition, the hypertension disease is worsening, you may have to look for a secondary cause of the hypertension, that is secondary hypertension. Maybe the kidneys, the renal vessels are duplicated or constricted somehow, and so on and so forth. All these things may come into the picture. That may be the first time you may be able to detect these secondary causes of hypertension. Right. So that is what I put there. So this is how the history will go. Okay, and of course at the end of your history, let me just talk about the other component of the history so that we can come to the summary, right? Right, so let's come to our direct question, okay? ODP. Okay, so your direct question is going to, this one is going to look at, I'll put it here, symptoms related to the condition that you left out in the HPC. Okay, so those things that you could not capture under the HPC, you are now going to put them under the direct question. Okay, so these ones you are just sort of adding more what do you call it, flavor to your history, something like that. Okay, so maybe, and you can go in terms of the systems. Okay, you come from general, go to the systems. Okay, those symptoms that support or rule out other conditions, you are putting them together under the OEP. Okay, right. So that is what you are doing to add more flavor to your history. So that as you add these points, the picture will be becoming clearer. Okay. So let's say you are talking about frequency. So you are looking at obstructive symptoms of, and then what irritative symptoms of the urinary tract. Okay, obstructive and irritative. Add plus and minuses. Okay, they will all. So the positives and negatives are all important here. Okay, they are important here to add more spice to the HPC that you add. Then we come to what we call the systemic review. The systemic review here, we are going by all the systems, maybe cardiovascular, respiratory, GIT or abdomen. Okay, you come to your genital, urinary. Okay, you come to your nervous system, skeletal. Okay. So here, what you are doing when it comes to the systemic review, you are now going to take each system thoroughly to exhaust everything under that system. So this is like more or less a second look, ensuring that you do not miss anything in your history taking. So your cardiovascular, exhaust everything, all the cardiovascular system. It may be related or not related, but you just want to either get something in addition or get the baseline for the system. So this is more or less like get baseline for the system. Okay, getting the baseline for the system. And this is more like adding what you left in the HPC. Okay, you can take it as simple in simple context. So getting the baseline for all the systems with the systemic review, and then adding on the other question is adding on what probably you didn't capture in his HPC, because you can't capture everything under HPC, and then the history will be a little cumbersome. Okay, right. So the little, I will not say minor or small, what do you call it, features, which you still need to say or add to make your history more spicy, is what you capture in the ODP. So the symptoms related to the condition that probably most likely you left out or you reserve for other parts will come under the right question. Then this is just to make sure that you get the baseline for all the systems. So this will be a simple way for you to remember. Now beyond that, we go to the next one, can be the past medical history, surgical history. Okay, past medical and surgical history. So here we are talking about your diabetes, your hypertension, asthma, epilepsy, and so on. Now, if there was a surgical condition, maybe you had appendicectomy, you had maybe bowel resection for typhoid perforation, and all those things will come in. The time, what led, and so on. So that they still give the picture of the patient we are dealing with. Okay, then you can come to your drug history. So your drug history, are you on any long-term medication? Long-term medication, any known allergies? Okay, any herbal preparations or concoctions that you use? Those things will come into the picture for drug history. Then you can come to. So there are so many other aspects of the history you want to capture, depending on the patient you are dealing with. Okay. So after that history, you can come to family history. So family history, we are looking at familiar conditions. Okay. History of thrombophilia, hemophilia, and so on. History of maybe hypertension in the family, and so on and so forth. Okay, epilepsy, all those things will come into the picture. Okay, then you can draw the family tree to depict whatever conditions, cousins, and so on. Consanguinity, maybe there's some sort of, maybe the person is married to a close relative, and so on. Sickle cell patient you are dealing with, so your picture can also come in. Some would even think of conditions that can be acquired within the close living together of family members, for instance, tuberculosis and all that. Okay. So these things are captured under your family history. Right. Then you can come to your developmental history, depending. Developmental history. Maybe you've noticed that the person has some syndromic kind of thing. You may talk about the developmental history or nutritional history. Nutritional history, maybe you are dealing with a teenager. Okay, a teenager. So we want to talk about that, okay? But that becomes important. Nutritional history may become important in that case. They may be malnourished, they may be smaller, and so on and so forth. They are now pregnant. You can talk about the sort of nutrients they are getting and so forth. So depending on the person you are dealing with, a proper part, these components may come into the picture, right? So then you can come to your gyne history. In this case, your past gyne history. Okay, so your past gyne history, you are talking about your menarche, your flow duration. Okay, flow duration. Okay, and then cycle length. Okay, the cycle length, duration, and cycle length. Whether there are dysmenorrhea and other things, discharge after menses, discharge after menses, offensive or not offensive. Okay, cervical screening for CA service. Okay, breast cancer screening. Okay, so on. You are looking at your contraceptive use. Okay, contraception. Which ones are being used? Okay, hormonal or these injections and all that. Put them there. How long they have been on it? Any problem? Then you come to the partner. We can talk about the partner. Okay. So the partner, how many of them? Number. Okay. Okay. Then you can talk briefly about each of them. Then the current partner. Okay. How long they have been living together? How many times they have sex per week and so on. Those things. So depending on the history, what you are talking about, you can put all these things there. Right? So the partner and so on, you talk about them and then that can be captured. Alright. So you can, especially when you are dealing with infertility, the partner history becomes very important. Okay, then you can come to your OFS history. So your past OFS and then your current, your index pregnancies history. Okay, so you come to your OFS, obstetric history. Okay, so the past one, yes, you can just make it obstetric history. So you talk about maybe the parity. Okay, talk about each pregnancy, the first, the second, the third, each of them, post PNC, what happens? Okay, breastfeeding issues. Okay, then up to 5 years old, is the baby still alive and so on and so forth. Okay, so was the pregnancy prenatal care, ANC, were they uneventful or eventful? If they were, you talk about them. Did they end up in termination? Where was it the termination done? Was it done by insertion of drugs at home by somebody, unqualified person? Did it end up in a hospital? What type of procedure was done to evacuate the uterus? If the patient, the baby died, what led? Was it an early neonatal? Was it stillbirth? Was it fresh, macerated? So all these things. Breastfeeding, was the person exclusively breastfed? If they were not, what actually led to that condition? Why didn't she need support for breastfeeding and so on? Right, and then this of course may come into the picture if you are dealing with HIV patients. You want to know whether they are going to choose that or exclusive breastfeeding throughout, or they are going to go by what you call it, the artificial feeding for a long time, right? So these are the things that you want to look at. In our part of the world, we will do the breastfeeding exclusive, but we will not do the mixed feeding. Okay, right? Okay, so and of course talk about supplementary, complementary feeds. Okay, so complementary feed, we know breast milk is the totality. Everything is in there, right? So if you're adding something at the time, maybe within 6 months, then you're adding something, you are just supplementing because you have everything there. Okay, but beyond 6 months, now the quantity and other things have gone down. So if you add something, it becomes more complementary, and so that will tell you complementary fees and then supplementary fees and so on. So this is the one that. Then you come to the current one. Okay, current pregnancy or the index pregnancy. The index pregnancy, was that prenatal? How was it diagnosed? Using urine prognosticon test, or how was it done? Okay, How was the pregnancy diagnosed? Okay, the dating scan. When was it done? How many scans has she had? Okay, right. Then we go through the steps. Okay, booking time. Okay, then booking scan, booking labs, any abnormalities detected in the labs. Okay, the visits. First visit, second visit, from first trimester visit, second trimester visits. Okay, anomaly scan done. Did they detect anything? So you come to your 24 weeks, 28 weeks, 34 weeks, 36 weeks, 38 to 40 weeks, 41 to 41, 2 weeks, beyond 42 and so on. So all the things that the patient will need to do. Okay, did we use universal screening for diabetes because the person was at risk? Did we decide we will screen her again at 24? Okay, if it is 24 to 28, okay, if it is what do you call it, the resource ISO organization kind of thing that we are dealing with, 28 weeks, what are you doing? Are you going to repeat close to 10, okay, or at 10, okay, or after maybe taking call, you decide on, do you want to give, do you want to check Coombs test, indirect Coombs test before you give, and so on and so forth. So all these things will come to the picture and we'll discuss them under the various topics. So this will be under the OPS history. Right. Then we come to your social history. Social history. So social history. So we come to social history. So here you are looking at, is the person married? Okay. Job. And the person's job. Okay, how much he earns. The partner, how much he also earns. Altogether, how much do they spend maybe in a month? Okay, their religion. Okay, do they accept blood? Right. How are they preparing to take care of the child? Any social support? Would they need somebody to take care of the child for them and so on? All those things can come into the picture under this one. Okay, so that would be the social history. So when you are done with the social history, then you come to the summary. Come to the summary. So the summary, like I said, I have, let's say I have presented Madam A.O. Gravida 4 para 3 or alive. Okay. At maybe 36 weeks. That's for gestation. Okay. Who presented with, okay, so the cardinal signs of the disease, or who was referred on account of high BP from La General Hospital. Okay, so who was referred from maybe on account of this. The cardinal symptoms of the disease is what you are going to capture, and currently being investigated for confirmation of the condition.